Thanks, everyone. I'm Chrissy Eibner from RAND Corporation. Just briefly, I'll give you an overview of what RAND is. We're a research organization. We're nonpartisan. We're not for profit. We do academic research as well as research for federal clients, for state clients, for California Healthcare Foundation, which sponsored this study. And so this work that we did was on reducing healthcare spending in California. And we aim to look at what other states were doing and what other promising options for reducing healthcare costs exist and what could be a template for going forward in California. So you've already seen these kinds of slides. I won't spend a lot of time, but healthcare affordability, as we know, is a major priority here, as it is throughout the country. And you know, many of these concerns stem from personal experience. 44% of the California population has reported that they've put off care or not gotten the care that they need because they couldn't, because of the cost. It was unaffordable to them. Okay, another fact that has come up throughout the day is that there's wide variation, both across the country and across the state, in terms of what people are paying for the same healthcare services. And this slide is just for two common services, cesarean delivery and knee replacement. And you can see there's large variation across the US, within California, and then across cities in California in terms of what people pay for these exact same services. Okay, so with that backdrop, we recognized that there was a large opportunity to potentially reduce cost in California. And what we did for this project is we looked at the literature on what are potential cost savings. We talked to a bunch of experts within the state about what options they saw as being promising on the table. And then we tried to assess what is the evidence base for each of these options. So there were 17 options in total that we considered, grouped into 5 categories, and you can see them here. 17 is way too much to cover in this time period, especially at the end of a long day when the next thing is cocktail hour, and I know people want to move on to that. So I'll focus on 5 in specific that are highly policy relevant here and have been getting a lot of attention both within California and nationally. So I'm going to start with an option, global payment. What global payment is it's when a health insurer or a payer provides a provider with a target amount for a given set of services for a given population over a given period of time. If the provider is able to meet that target or come in below that target, they will share in whatever savings between what they actually was spent and what the target was. But if they go above that target, they have to bear some of the cost of having exceeded that target. And typically these global payment contracts work in quality incentives, and that's to avoid a situation like we saw in the 80s and 90s with capitation, where the possibility was that you address capitation by skimping on care. Okay, so global payment has been tried before, and there are some promising results. I want to draw attention to the Blue Cross Blue Shield of Massachusetts alternative quality contract. Very recently, there was a study in the New England Journal of Medicine that looked at the outcomes for this global payment model. BCBSMA has been doing this for now over 10 years. The recent study found 12% savings over an 8-year period. And one of the things that we learned from this analysis is that savings increased over time. So, it's extraordinary to be able to look at something like this over a long period of time, because often what you learn in the first couple years after a new health reform policy is implemented may really not reflect what the long-term effects are. And so looking at this over this 8-year period was really exceptional. We saw that the savings increased over time, and there were no adverse effects on quality. So this is a promising option. Now that's of course one health insurer, and there's a question of, well, what could the state do? Global budgets are a related option that can be implemented at the state level, and this is where the state would impose some kind of payment target for a given set of services. And that's taking place right now in several states, Massachusetts, Vermont, and Maryland. I'll walk through the Maryland example in a little bit more detail. So Maryland has been moving on a continuum of global payment or global budgeting for years now, starting in 2010, when they implemented global budgeting for rural hospitals. So they set a budget limit for each rural hospital, and then the hospitals were accountable for holding care within that limit. In 2014, they extended the model to all hospitals in Maryland, And the recent CMS evaluation of that all-hospital global budgeting showed 2.7% savings for the Medicare population with no adverse effects on quality. There was no change for commercial payments, for commercial payment patients. So not savings in every corner, but Medicare is a big segment of the population. In 2019, they expanded this model to encompass total cost of care, so not just hospitals, but now all care. And so it remains to be seen how that goes, but promising effects early on. Okay, so what are some policy options for California? One would be to encourage the use of global payment, either by using, as a bully pulpit, just encouraging insurers to enter into those types of contracts, or to implement those kinds of contracts in CalPERS and Medi-Cal. Additionally, the state could consider moving to a global budgeting approach along the lines of what's being done in Massachusetts, Maryland, and Vermont. Okay, so now let me move to out-of-network billing. This is another potential option to reduce cost, although it depends what perspective, whether you're the consumer or the system as a whole. As was mentioned, as Hemi mentioned, California is one of the states that has the most comprehensive protections already in terms of protecting citizens against out-of-network billing. It's one of the top 6 states according to a recent study by the Commonwealth Fund. And here's just a list of some of the things that California is currently doing that provide protections against out-of-network billing. AB 72 protects fully insured enrollees from surprise bills from an ancillary provider at an in-network hospital. There was a 2009 Supreme Court ruling that protects people from receiving surprise bills from emergency departments if they're in plans regulated by the Department of Managed Care. The Fair Pricing Act of 2006 protects low-income uninsured consumers from facing excessive charges. And then California also has very broad network adequacy protections relative to other states. And this is important because if your network is broad, the likelihood of facing an out-of-network charge is lower. Even still, we find that almost a third, or this is from the CHCF KFF health policy poll, that survey found that almost a third of Californians have received an unexpected bill. So if you recall from Liz Hamill's talk earlier today, this is lower than the national average, which perhaps reflects California's relatively protective legislation, but still it's like 1 in 3. And so one reason for that may be that there are gaps in protections. So as Hemi alluded to before, one important gap is self-insured plans. So if a plan is self-insured, and about just under half of California's commercially insured population is in a self-insured plan, then ERISA preempts the state from regulating the insurance, the contract between that self-insured employer and providers. And so that has been interpreted to really restrict the ability of a state to do anything that would restrict out-of-network billing for enrollees in self-insured plans. And so these protections don't extend to people in self-insured plans. Out-of-network ambulance service and bills for inpatient stays originating in the ED are not included in the protections. And then the out-of-network emergency department bills the protections only exist for people in plans regulated by the Department of Managed Care. If you're in a plan regulated by the California Department of Insurance, you don't have those same protections. So there are some gaps here. So there are a few things California could do to try to fill these gaps. One would be to extend the out-of-network billing for emergency department services to the people who are enrolled in CDI regulated plans. That seems like a simple one. Potentially extending protections to cover ambulance services and inpatient stays originating in the ED. And then also thinking creatively about how to address enrollees in self-insured plans. So the options are limited here, but there are some options that might work. So for example, requiring ancillary physicians to contract with hospitals might be a way to effectively reduce out-of-network billing for that population, and it doesn't require directly interfering with the self-insured employer and the provider contract, and so it may get around ERISA. One important point about this, with out-of-network billing, the goal is to reduce the consumer's out-of-pocket exposure. That could be done in a way that reduces total cost of the system, but it wouldn't necessarily have to reduce total cost of the system. So if we require insurers to pay whatever the emergency department is charging, or whatever the provider is charging, that could potentially increase cost. On the other hand, an out-of-network protection that limited what could be charged might be more likely to reduce cost. And so it's important to consider, if you're thinking about this as a policy to reduce overall healthcare spending, how this works in terms of the leverage and negotiation between the provider and the payer. Okay, let me move now to health plan regulation. So again, some statistics that won't be surprising. We've seen something like this from several of the different presenters throughout the course of the day. Health insurance cost, health plans have become increasingly unaffordable, and this includes not only premiums, but also deductibles, and it affects both people in employer-sponsored health plans as well as individuals who are on Covered California or other individual market plans. So one option to try to address these rising healthcare costs would be health plan regulation. And just to speak to an innovative example from one state, Rhode Island has implemented what they call affordability standards for commercial insurers. And these standards are lengthy and fairly complex, but basically what they're doing is they're requiring insurers to reform payment contracts to reduce annual increases in payment levels. They're requiring insurers to move towards value-based contracting, value-based purchasing, DRGs, and they're also requiring insurers to increase spending on primary care with a focus in specific on patient-centered medical homes. And so these have been in effect now since 2010, and a study came out in Health Affairs that looked at the impact of these regulations. And it found that there was a reduction of about 5.8% in spending among the commercially insured population. And you can see that broken out here in this chart, a $76 per enrollee per quarter reduction in fee-for-service spending. That was somewhat offset by an increase in non-fee-for-service spending, and that's of course because this law requires movement to value-based payment, but in net a $55 per quarter per enrollee savings, which again translates to about 6%. Now, California is very different from Rhode Island for many reasons, and the Rhode Island law is also fairly complicated, potentially somewhat heavy-handed in terms of all the different requirements that apply. So, you know, is there a less onerous kind of approach that California could take? Well, one fairly simple thing is currently California, like many states, has rate review of health insurance premiums, but California regulators lack the ability to deny rate increases that they deem excessive. And there was a study that showed that states that have that authority to approve or deny rates had lower premiums. And so if we extrapolate from that study, there would be about 4.6% savings. I have to caveat that this study was for the individual market only, so I'm not sure whether it would generalize beyond the individual market, but at least for that population, there could be savings associated with this change in regulatory procedures. Okay, so the public option. So this came up before. So California could implement a public option on Covered California. And just to set ideas about what we're talking about with a public option, as we have viewed it, a public option is a plan that has access to publicly negotiated rates. So those could be Medicaid rates, Medicare rates, some kind of percentage off of Medicaid or Medicare or something like that, but publicly negotiated. And so that is likely the main source of savings from a public option. It's also possible that a public option could reduce administrative cost. For example, if it piggybacks off existing larger plans, Medicaid plans, for example, or if the elimination of a profit motive leads to reduced administrative costs. So one question is, well, how much money could a public option save? A challenge in estimating this is that it has not yet been implemented in any state. We know, Washington has it on the books, also Colorado, but it has not gone into effect. So we have to rely on estimates. And so if we look at the estimates, both RAND and CBO have looked at this. The savings are 6 to 8% according to these estimates, but we'll know a heck of a lot more when we see what actually happens in Washington, which will implement the public option starting in 2021. One consideration for implementing a public option, and Hemi brought up that in Washington state, the public option requires that the average payment rate is 160% of Medicare rates. Well, as Hemi noted, it was difficult to get to that 60% of Medicare level. But if we look at Washington and what rates are in the current individual market, they're not that much different. So there's an estimate that they're about 174% now of Medicare rates. So this 160% is not a large cut in payment, which means that the implications for how this affects total spending, it could be smaller than what some people may hope. Another issue to consider with a public option is to the extent that this is implemented on the marketplaces and really aimed at the population currently enrolled in the marketplaces, that population, the majority of that population receives federal tax credits to purchase health insurance. And the way those tax credits are designed, they cap the individual's out-of-pocket spending, premium contribution as a % of income up to and then the federal government then covers the cost up to the price of a benchmark plan. So if the implementation of the public option reduces the cost of the benchmark plan, the savings are going to accrue to the federal government, not to the enrollee. With the exception of people who have higher incomes who are not eligible for the tax credits, and those people will receive some savings, and that's an important population. California does have protections in place because they've extended the limit for receiving APTCs to a higher income level. So these savings are really likely, from the individual's perspective, to be mostly for higher income people, which is another consideration in thinking about a public option. Okay. Final policy, expanding scope of practice for nurse practitioners. So this is, the scope of practice for nurse practitioners varies substantially across states, and California is one of about half of states that does not provide full practice authority to nurse practitioners. What I mean by full practice authority is the ability to practice independently and also to prescribe independently. So we know that nurse practitioners cost less. They can provide lower cost care than physicians. And so here are some estimates of the difference in cost for various services related to primary care. And they range from 11 to 29%. So there's a cost savings associated with moving to utilizing this population or these providers more. One concern that's frequently raised in this context of extending practice authority for nurse practitioners is the potential effects on quality. And study after study has shown that is not really a concern. So this is a study that I thought used a clever design of considering what happens in states that have expanded practice authority to nurse practitioners, what happens over time in those states to various measures of quality. And you can see that this study found improvements. Increased the probability that an individual had a routine checkup, an increase in the probability of having a usual source of care, an increase in the probability of rating care quality as excellent, and also an increase in the probability of rating health status as excellent across these states over time. So that's what the evidence is showing. We also see in this study fewer emergency department visits when nurse practitioners have more scope of practice authority, which may be related to the first two columns here, that if you have a usual source of care, you may be less likely to use the emergency department. Okay, so a lot to digest here. So I think the bottom line is that there are many promising options for reducing costs in California. Now, California is a unique state, and that also has to be taken into consideration. One of the major differentiators between California and other states, and there are many, but California has a larger penetration of managed care than any other state. And so to the extent that some of these practices have already been adopted by managed care, maybe the savings will not be as significant, or there may be less low-hanging fruit. And another thing to consider is that the state may need to pursue multiple options. So while these savings that I've described oftentimes look very good, if you kind of look at the total health spending in California and think about what it would look like if we made this policy change, it's small relative to the total amount that's spent. And so to really make a significant dent, it may be necessary to implement more than one policy change. But I want to close by just pointing out that California has so often been a leader in terms of policy innovation, and really a beacon for other states. And so the rest of the nation is looking to California right now to see what are options that we could utilize for reducing healthcare spending. And so I think it's exciting to see California thinking about leading the way once again with different ways of containing healthcare costs. Thank you.